What's going on, wonderful people? Okay, let's jump right into this explainer with a pretty high-stakes question. What actually happens when a rogue blood clot deprives your tissues of oxygen and nutrients? It's all fun and games until we start talking about thrombosis. Today, we're grabbing our markers and mastering anticoagulants, those absolutely critical medications that stop deadly clots right in their tracks. So here's our whiteboard syllabus for today. 1. Introduction to clotting. 2. Classification of anticoagulants. 3. Mechanisms of action. 4. Side effects and contraindications. 5. Antidotes and special effects. And finally, 6. Pharmacotherapeutics and treatment. We're going to break down the entire coagulation cascade into bite-sized pieces so you can completely crush your exams.
Section 1. Introduction to clotting, the pathophysiology problem. Let's define the playing field of hemostasis, because you absolutely have to understand the disease before you can understand the drug.
All right, first things first, vocabulary. Imagine a thrombus as a clot that's just stuck. It's adhering to a vessel wall. But the second that thing detaches and goes floating through your bloodstream, boom, it becomes an embolus. And that is highly dangerous. A detached thrombus is an embolus, and both of these can literally be fatal by plugging up blood vessels and suffocating your vital organs.
Notice how I'm mapping this out here because it perfectly shows the difference in where these clots form. Arterial clots, usually springing up in medium-sized vessels thanks to atherosclerosis, are just packed tightly with platelets. On the flip side, venous clots, think of a DVT or deep vein thrombosis, are triggered by blood stasis, when the blood is just sluggishly sitting there. These ones are super rich in fibrin, so it's platelet-rich in the arteries versus fibrin-rich in the veins. Definitely jot that down. Section 2. Classification of anticoagulants, the pharmacological arsenal. Now that we know our enemy, let's look at the heavy hitters we use to fight these clots. We basically group these drugs by how they get into the body. Over on the left, following the blue marker, we've got the parenterals, the injectables. We're talking heparin. Low molecular weight heparins are LMWHs like enoxaparin and argatrobin. Then over on the right, in red, we have our oral pills, warfarin, and the newer direct oral anticoagulants like Dabigatran and Rivaroxaban. Next up, Section 3, Mechanisms of Action, Stopping the Cascade. Let's see how our drugs actually block this coagulation cascade right at the source.
Let's start with heparin. Now, heparin doesn't actually work alone. It's more like a super aggressive wingman to antithrombin 3. When heparin binds to this endogenous inhibitor, it kicks it into high gear, causing this rapid conformational change that totally shuts down thrombin and factor XA. It's a fast-acting injectable that stops thrombi from expanding dead in their tracks.
Check out the large negative charge on the heparin molecule we've drawn out. Because it's this massive macromolecule with a heavy negative charge, it actually stays trapped right inside the vascular system. It gives you immediate anticoagulant effects without wandering off into other tissues. And hey, this is exactly why it's the go-to anticoagulant for pregnant women. It is literally just too big to cross the placenta.
Now, unlike heparin, warfarin plays the long game. It blocks the enzyme vitamin K epoxide reductase right in the liver. This basically starves your body of the active vitamin K it needs to build clotting factors 2, 7, 9, and 10. It's pretty genius. But keep in mind, it takes about 72 to 96 hours for the peak effect to hit, mainly because you're just waiting for the already circulating factors to naturally run out.
As for our newer oral agents, the direct oral anticoagulants, the targeting is insanely specific. Dabigatran goes straight after thrombin. Meanwhile, the drugs ending in Apixaban, like Apixaban and Rivaroxaban, cleverly ban factor XA. Apixaban, they ban XA. See what they did there? It's a ridiculously easy mnemonic. Totally keep that in your back pocket for test day. Section 4. Side effects and contraindications, the trade-offs. As the famous economic rule goes, there are no solutions in life, only trade-offs. We're stopping deadly clots, sure, but what's the risk? Let's examine the dark side of these drugs. This table I'm drawing out right now, absolute gold for your exams. Bleeding is the universal side effect across the board, so just lock that in. But let's look at the unique ones. Warfarin can cause this rare, painful condition called purple toe syndrome, and like we mentioned, it is a massive no-go in pregnancy because it's highly teratogenic. And heparin? Well, heparin has a very unique allergic hypersensitivity that you absolutely must commit to memory. That reaction is HIT, or heparin-induced thrombocytopenia. If your patient is on heparin and suddenly their platelet count just nosedives, you are looking at HIT.
It's this wild immune-mediated reaction that paradoxically increases their risk for venous and arterial embolism. So, what do? You stop the heparin immediately and switch them over to a direct thrombin inhibitor like argatrobin. No hesitation.
Moving right along. Section 5. Antidotes and special effects. Reversing the bleed. What happens if your patient gets too much medication and starts bleeding profusely? We need a backup plan.
You have to give them the right antidote. Protamine sulfate is a weak anticoagulant that ionically binds to heparin in a 1-to-1 ratio, giving you an immediate reversal. For warfarin, the antidote is vitamin K, which overcomes that enzymatic block we talked about. But there's a huge catch. Vitamin K takes roughly 24 hours to actually synthesize those new clotting factors.
And if your warfarin patient is actively bleeding out, you simply cannot wait 24 hours for vitamin K to do its thing. You've got to hit them with fresh frozen plasma or whole blood to rapidly replace those depleted clotting factors right then and there. Oh, and what about the DOAC Dabigatran? For that, we actually have a highly specific reversal agent called idarucizumab that neutralizes it completely, almost like magic.
Last but not least, Section 6. Pharmacotherapeutics and treatment. Taking it to the clinic. Okay, let's step into the hospital ward and see how this plays out in a real-world algorithm.
Watch closely as I draw out this flowchart. We monitor warfarin using the INR, the International Normalized Ratio. If a patient rolls in with a dangerously high INR of, say, 10.5, step 1 is always hold the drug. Step 2, check for bleeding. And step 3, administer oral or IV vitamin K depending on the severity of the situation. It's a super delicate balancing act.
A really crucial point in clinical practice is managing drug interactions. For instance, if you give a warfarin patient a common antibiotic like sulfamethoxazole trimethoprim, it actually inhibits warfarin's metabolism. That means the warfarin just builds up in their system, shooting their INR and their bleeding risk straight through the roof. You've got to dial back their warfarin dose and monitor them relentlessly.
So, knowing this incredibly delicate balance between preventing a fatal clot and risking a fatal bleed, how are you going to manage the ultimate trade-off in your future patients? Are you going to master the mechanics of these lifesavers, or are you going to let the cascade control you? Think on that, stay sharp, keep learning, and we'll catch you in the next explainer.